Bettina, you've got headaches, but you don't have any at the moment. Any other symptoms that you want to confess to? How often do you get the headaches?
Probably once or twice a month.
All right.
Yeah. Numerous days at a time.
Numerous days, that's very good. Whereabouts are the headaches? Around the back?
Sort of start at the back of my head and then make their way forward.
All right, so there's patterns of referral, but it's not part of this course. But anyway, we'll go back to basics and
upper cervical.
Yeah, upper
And
cervical.
then I get really, tight through my upper traps, and I can feel it's my throat is fine.
Sorry?
Are there any pre-existing injuries or?
No. All right, so we scan her body, her shoulder slightly forward on that side, her trunk is off to one side, it's a bit dumped down as well. You can feel there's a difference between these ribs and these ribs. So you take it all in. Whether it's going to be important to us or not is another story, but we take it all in because then we can note the changes in the system. So her head, slightly off to the side a little bit, okay? Is it significant? Well, we'd love to be upright. Okay, so you don't feel anything right now. She's asymptomatic at the moment. So we'll get your feet on the ground. And what I want you to do is just do a cervical extension. So look up at the ceiling and then come back down. What did you guys see?
Can you do it again?
That's what I saw. Something clumped. Did you feel that? All right, so go again for us. So her head sits this way, but when you extend, it comes back around. Have a look again. You guys see it?
Yeah.
So go again. So how it sort of comes this way and then it,
But it's not all coming from the neck, is it? Isn't the neck coming?
yeah, so what we're looking for is dysfunction because we don't know where that problem is. So when we do our tests, they're just positive tests. We don't assume that it's one muscle or the other until we break down our testing, but we have a positive test. So we're looking for all the positive tests so that when you do your intervention, you can reassess relevant to all those positive tests. For all we know, that could be coming from her pelvis downstairs. Yeah, and I correct this and her neck comes out better. But we start with what we know and we start locally because as far as the patient's concerned, I've got a neck problem, why are you messing with my pelvis on that first session? All right, so that's the cervical extension. I'll get you to do the cervical flexion. So I'll get you lying on your back. And all I need you to do is lift up your head against gravity. Now, stop. As she lays down there, I'm looking at her body and I'm looking at the lineup just to see where it is and just to see whether she thinks it's normal. Now, if I'm standing here, I can actually see her head is side flexed to the left, which correlates to her upright position. So that's consistent. Can you feel that? No, that's all right. Sometimes people lie skewed and they think that's straight. So again, their proprioception, sense of self in space, has been altered and sometimes we need to re-educate that. Okay, so lifting up your head against gravity there, hold, and come back down. How does that feel? Fine. Any shakes in there? And come back up. All right, again, it's still held to one side as she comes up. You can't feel that, yeah?
No.
All right, so in this position, I'm going to start testing her muscles. So we've done the cervical extension and the cervical flexion test. If I rotate her head fully, then I put her sternocleidomastoid into an anti-gravity position, don't I? So from this position here, I'll hold her up in the air there, and I'll ask you to hold your head up in the air. Notice my hand is right underneath it. I just take it away for now. I'll hold your head, just have a break. You want your hands to be there just in case you can't hold it. That way you're there to catch it, just in case, okay? Hold the hand there, head there. I'm going to put my hand down in the line of the sternocleidomastoid, just above the ear. I'm going to push your head down towards the bed, and you want to hold that. And relax. All right, let's do that again on the other side. Sternocleidomastoid, anti-gravity position. Hold her head up there. Hold there, don't let me push you down. And then relax. It's a little bit weak. Do you feel it?
Yeah.
Am I trying to break her neck? No, I'm slowly applying pressure. As soon as you feel it starting to give, you think about how much force is going into that, you'll notice, you may not have noticed, but I know what I did. I didn't put that much force, and her neck wanted to give, so I didn't keep pushing more. I just recognised beyond that, I don't think your head would have helped. Would that be correct? And the reason I know that is it was giving as I applied resistance. So if someone's irritable, do you think this is an appropriate test? No. Okay, so you'll find an alternative. You might palpate instead, but you will use something else. This is an anti-gravity position. It's a provocative position, but she's not irritable. She doesn't have any symptoms at the moment. If I rotate it slightly, so slight rotation, 30 degrees, and laterally flex, just relax there, I'll bring the scalene's origin insertion together. At that point, if I lift up her head and hold it towards the shoulder, this time I'm applying in this direction. Hold there, don't let me push across, throw from ear to ear. She's got no hold. Did you see that, guys? From here to here, hold there, nothing. So I would say that test for scalenes is more positive than her sternocleidomastoid test.
I'm just not as good with the neck. What do the scalenes do again? Like,
So scalenes, they do exactly the same thing as sternocleidomastoid. So they flex, laterally flex, and rotate. The only difference is they attach themselves to different areas. So your sternocleidomastoid attaches to the sternum, the clavicular, and the mastoid process, whereas your scalene attaches to the transverse process of C3 to 6 down to your ribs. So because they're attached lower and exist more laterally, you're testing a bit more laterally, as opposed to an AP plane, which is more your sternocleidomastoid. It's more closer to the midline. Does that make sense? So one goes here and one goes in that direction there. So you position to bias the muscle, just like we did in that hip lab, in that hip example. When I position the hip in a different angle, I bias one muscle compared to another. They're all synergists, so they don't work in isolation. However, if I position in the right way, I will put more emphasis on one muscle over another, and that directs me into where I will place my taping for a correct intervention. Okay. Let's do the other side. So 30 degrees rotation, not full rotation, lateral flexion, hold there. Thenar eminence, ear to ear, hold, don't let me push. That's quite weak too. And I'm not pushing that hard.
No.
And there really isn't any resistance to my movement.
No,
There's nothing there. Yeah, so here's the thing, she can still lift up her head and she doesn't think it's any effort, and when I'm done you're going to say my head just floats up. Yeah, because you can see that this is a muscle that really should be strong. It's holding your head, dictating neck position and movements. It's really quite weak on testing. In her personal reference of body movements related to the neck, they help to lift up her head and she thinks it's normal. So I come to a couple of conclusions about that experience for her. She's had it for a really long time. Because her reference of this neck is, when I lift up, that feels pretty normal. But yet when I test specifically, it's actually really quite weak. So she's had it for so long, her brain just assumes that this is her normal function. And what we know as therapists, it can be a whole lot better. So I'm expecting that the other test, whilst in her mind it wasn't positive before, it will be a positive test after I do my interventions, and these should change with my intervention as well. Okay? So I'll set you up for the next test. So in your groups, what I want you to do is, if you've got pens, you're going to ultimately forget what you just tested. So I'm going to nominate two colours. So I've got two colours here. I'm going to nominate pink as being weak, yellow as being tight. All right? So I'm looking for her sternocleidomastoid. It's not the sternocleidomastoid, but it is the scalenes, and I'm just going to put a W there for pink. If you've got, put a W if you've only got one colour, otherwise just mark it. And both are weak. You're not going anywhere tonight, are you?
Yep.
It's a whiteboard marker, so we should come off.
It'll come off.
I might just change over to one of the black markers, and it might come off more easily for you. Oh no, that one's dead, and we've broken it. I'll use that one. So remember, these are only $2 from Kmart, so or any cheap store these days. So, all right, so they're weak. Right. Now I need to test for the length. Remember, to know whether I'm doing muscle length or strength, I need to then figure out, am I taping to restore strength or length? All right, so sternocleidomastoid attaches to the sternum. It is a bit more anterior and runs posterior. So the wind up for the muscle is so I'm going to do the left-hand side. I'm going to place my forearm on her shoulder. The reason being is if she starts to move it, it'll pop up and I'll know that's her end range. Slide the hand back so I get my fingers on the chin, other hand on the head. I'm going to get her to look up towards the ceiling, wind up the AP line first, then I can rotate or laterally flex, but I wind up with the extension first, and now I laterally flex. Laterally flex. Little lateral flexion. Remember, so sternocleidomastoid extends, laterally rotate, it laterally flexes and rotates away. So you want to, if you want to test the length of it, you want to rotate towards it, as well as extension, lateral flexion. And how we buy sternocleidomastoid before scalenes is to wind up the flexion extension first. Okay, the extension range, because it's more anterior. As opposed to scalenes. Scalenes, the same hand position, forearm on the AC, fingers on the chin. I laterally flex first. Sorry, I laterally flex. Can you see how she doesn't go? So which is more positive at this point? Sternocleidomastoid or scalenes? See, sternocleidomastoid, I got a couple of components before I came to the block, whereas you see the scalenes, I'm coming to a block almost straight away. So at this point, my scalenes length test is more positive. Does that make sense? So I'm rating not only that it's positive, but how positive is it? So I go into lateral flexion, it doesn't really go. I go into extension, she doesn't really, I can force it there, and rotation, and we really wind up early. Yeah? You can feel that?
Yeah.
So,
I don't want to go there.
don't want to go there. So it is weak, and it is tight as well. And that's the left-hand side. Let's do the other side. So let's do scalenes first. So lateral flexion, pretty stiff. Extension and rotation. Yeah. All right. So this side, weak and tight as well. So I don't care what you write, so long as you mark it down for yourself so you know what you're doing. Forearm, chin, head, extension. See, this is good. Rotation, also good. Lateral flexion is where it gets stuck. And again, the lateral flexion component winds up with scalenes because it attaches more laterally. Does that make sense? All right, so we've definitely got a positive test there around the front. Now we need to test the muscles around the back. So remember the spina cervicis was the lab before. So what we want to do is we want to rotate the head slightly, and then I'm going to stabilize the shoulder and the thorax as I lift her head, so that way is the force of my hands. I'm going to lift the occiput off as she flexes. How does that feel? And that's a little bit tight compared to that one. And that's quite tight as well. You can feel that it's tight. Would I say it is tighter than this? No. So I can put down that it's tight. I can highlight to myself that that would be a positive test. I could reassess with it. It might be significant. At the moment, my most significant tests are here, aren't they? Okay. For this normal neck today. And as I said, I'm sorry, I'm okay with you feeling normal today.
Okay,
I can put you
so
through your
am I.
paces. But we can certainly see why you might have some
Yeah.
problems.
Yeah.
All right, so now what I'm going to do is I'm going to get you lying face down, and actually this has got a headpiece, which is actually better again. Who's better at like thank you? Thank you guys also for being in the beds. Is there a piece to go in here? Anyway.
Closer to the back.
Oh, yeah.
In the middle. Ready?
Perfect. If you've got a bed, a sort of a cervical piece that you can actually drop the bed head with, it's actually better because when you do your cervical extensor test, you're better off actually putting it in slight flexion so they only have to go to neutral. Otherwise, it's a whole lot of work for your patient. So I'll get you lying face down with your head through there.
Ready to start?
All right, so with this cervical extensor test, so splenus cervicus or capitis, what we're asking the patient to do is hold their head up against gravity with a slight rotation to the side. Hold it there. I stabilize the thorax, place the heel of my hand above, and hold there, don't let me push down. And you can't hold that. Hold there, don't let me push down, and there's nothing there. Hold there, don't let me push down, and there's nothing there. This one's a little bit better than the other side. Yeah, slightly stronger. Hold there, don't let me push down. All right, so we have some issues there. Versus the big lever, which is splenus capitis. So you can do it mid-range or all the way rotation, so fully rotate. Hold there, don't let me push down, and again, we don't have great with strength. Hold there, whoops. Don't let me push down. Don't have anything there. All right, so we've got a whole lot of positive tests. Have a seat. So in my list of things that I want to assess, I need to assess that, facing those guys.
Oh, still there.
I need to assess her extensors for length and strength. I need to do something about her scalenes. So that's weak as well. Right. So her whole neck's a bit dodgy. So where do we start? All right. And we start with the most significant. You're absolutely right. I'd be starting with the scalenes. In terms of your positive tests, they were the most significant and positive, weren't they?
We'll just work on one first just to see the effect on them.
Of course, I always do, yeah. So in this point, at this point here, I've got two scalenes that are pretty much relatively equal in terms of their tightness and their weakness. Around the back, there was a better differentiation. The right side was slightly stronger than the left. So if it was about the back muscles, I would choose to take the left before the right. In the front, they're pretty equal in terms of my orthopedic testing. So the next question is, which side do you feel the symptoms most?
I think it's usually my left.
Left. And not to say that symptoms are related, but did any of those tests reproduce a hint of symptoms as well? That's a shame. Because obviously, the tape also manages pain. So if you can get, all three in one go, I would choose to do that particular taping because all things being equal, muscle length and strength are the same. They're both in deficit. Okay. So at this point, have you had any shoulder issues on your left versus right? Because we know those things will affect shoulder mechanics. So basically so what we're searching for is a 2-for-1. We want to treat two areas for one because at this point, that's pretty equal. So you had a rib last week on this side, so I'm going to choose this side. Yeah. My hypothesis is this might be the primary side to work with, and it can create the rest of it, the rest of the other problems. I'm happy to be wrong. I will commit to a diagnosis and be okay to reevaluate that diagnosis. And I can't stress that enough for you guys. When you do your treatments, commit to something based on the evidence you have. And if you reassess it's not what you want, then be okay to be wrong. You don't have to be perfect all the time. But if you never commit to anything, you don't really know what you're treating then. Okay. So I've got her scalenes anterior, middle, and posterior. So what I'm going to do is I'm going to trim the tape to meet those components. So the scalenes are bordered by the sternocleidomastoid and the upper trapezius. So you must make sure that your application of tape stays in that triangle, if that's what you're planning to facilitate. I have no problems with you taping combined sternocleidomastoid and scalenes, and that tape will then come across both muscles, but in this case, if you plan to do scalenes, then stay on scalenes. So what I'm going to do is stretch around and I'm going to orientate myself to the sternocleidomastoid, hitch up just a little bit, and then I'm orientating myself to her upper trapezius, and I know that I want my tape to stay in between that triangle. And that way I remain anatomically correct for that patient. I'm going to trim my tape down the center into 3 components. So I spread my tape, it's a fan cut, and I spread my tape around that muscle because you've got anterior, middle, and posterior. I've gone to the trouble of cutting this tape to fit in that groove between the 2 muscles. Where do you think I'm going to start my tape? Irrespective of whether I think it's a length or strength. Can you see why I would do that? It's actually harder to come with 3 pieces of tape starting at different points, coming down to the same point at the correct tension. Yeah, so it's easier for me to anchor the common point and then work each tail independently. So I tear off my tape, place her into position, so lateral flexion, extension, and then rotate as much as she can. Now when I rotate this way, I bring the tissue together. Can you see how it is actually gathering the tissue? So with this one, I'll extend, I'll actually rotate the other way as I laterally flex so I can stretch the tissue more. So while the testing is rotation towards, when I apply the tape, I'm going to rotate away just so I can get maximum tissue stretch. I anchor the tape in on the groove with no tension. When I apply the arms of the tape, I'm mindful which component I'm placing tape on. So if I'm doing the anterior scalenes, it's more AP directed, so I'll bias it with extension. I'm very light with my handling. I want a relaxation effect because it is tight and weak, yes? Remember with our testing? So because she's quite weak, tight rather, I'm going to push her skin up as I roll the tape down. And then anchor at the end with no tension. I'm doing the middle component here, so it's somewhere in between the lateral flexion and extension. So again, pushing the skin up, being very light with my handling of the tape.
Is that to give it more of a facility?
No, so I'm trying to relax the muscle,
Oh, sorry.
but so I want to really keep that tension off because I certainly don't want to ramp this up anymore.
Yeah.
It's so tight. She hardly had any lateral flexion, so she needs to restore her lateral flexion. And so again, here I'm going to come to the side. So I'm biasing the lateral flexion component of things, and I'm really trying to push the skin up as I roll this tape down. And then I rub the tape to activate the glue. Depending on how irritable it is, you might rub the glue gently. It's very tight in there, by the way, in case you can't feel. Right, that's her scalenes tape. All right. It's in a bit more neutral position. Not that she noticed there was change anyway. All right, obviously, I could do the other scalenes right now. But I really want to assess whether this is the top of the hierarchy. And it might be that I need to do both, but we'll see, because she had a rib problem on this side. Often her symptoms on her left are worse. It would be a tension-related headache that she possibly gets. So, a couple of tests. Now, I've placed her in a lengthened position to apply the tape, so I'm not going to test her length right now. What I will do is I'm going to test the posterior muscles. So in other words, are these posterior positive tests secondary to the neck problem up front? Okay, so I'm going to rotate and flex, and that's heaps more flexible. You can feel that, can't you? I don't have the resistance in there at all. And rotate the other way. A little bit tight on this side still, but heaps better. I'm going to get you lying face down and we're going to test the strength in the, I haven't taped those, but my hypothesis is the other ones are more important and these things are secondary to the scalenes. Extension, hold there, don't need to push down. She can hold it. And the other side, pretty cool, hey? Yeah. Nice party trick, hold. This side's a little bit weak still. Yeah. Right, and then what else do we have? We've got you lying face up for me. Shuffle you down the bed just a little bit. Double checking your head. Still off to the right, left a little bit. Yeah, you feel not quite so straight. So I wanted to do the cervical flexion test because she thought it was normal, but do it now and see how you feel.
Heaps easier.
Heaps easier. All right. Even though she thought that was normal. But we knew that was going to be the case. Yeah? We predict that was going to be the case. All right. Sternocleidomastoid test. Slight rotation, lateral flexion, hold there, don't let me push across. It's still a little bit weak in here. Better, I can actually, she's got some resistance to offer me. It doesn't just go with me. I do want to test the other side. Hold there, don't let me push across it this way. And this is stronger. Can you see that? You can feel that too, can't you?
Yeah.
So at this point, yeah, this is improving just when I have the tape on this side. So it is the correct hypothesis that this is probably more important than this side, in the sense that if we pick the top of the hierarchy, everything improves. If we pick something in the middle, everything that's below it improves, but things that aren't related or aren't below it won't improve. Does that make sense? All right, so now I'm going to sit you up. All right, so now let's test lateral flexion. We've got some more movement. Can you feel it? There's still a block.
Yeah.
Where's the block? This side or this side?
This side.
And down here somewhere. There it is.
Yeah.
You can feel that cord there. In a bit, I don't have any tape on, by the way.
Yeah.
You can feel it though. You're like, just put put some tape there. You'll be fine. All right, so lateral flexion, there's a block a bit more posterior where I don't have tape. Extension and rotation, so much more range.
Yeah.
Yeah. Let's compare the other side. Lateral flexion, so we've got more lateral flexion. Extension, well, there's a bit of a block there. Was that this side?
No,
This side. All right, and then rotation. It's still a bit blocked on this side. It's better, still a bit blocked, right? So this stage, I think our hypothesis is right, that we're still restoring strength and length. Is it everything? No. You know exactly what muscle I'm going to go to next, don't you? On the other side. Does that make sense, guys? Because I've improved some of it, but haven't improved all of it. And her body's saying, please do. Now, before I get there, I could actually take this other component here. Yeah? You can feel it, can't you?
Mm-hmm.
So this is where my little leftover strips are nice and handy, because it's not a big piece of tape that I need. It's just her body's saying, what do I need? I want something right back here. And it's the type of body that's quite sensitive, and you can feel as soon as I do it, you get a feeling that the patients need it. And did you subconsciously say to yourself, not to, please?
Yeah.
Don't go to the other side yet until you fix this. All right. So again, I don't need to go up high. I just need to get onto the correct structures. And that's making a big difference, because I can feel that softening right off. You can feel it, can't you?
Yeah.
That one tiny strip. Lateral flexion, extension, rotation. Is that still grabbing?
Only
Tiny
tiny
bit.
tiny bit. Up a little
Let's
bit
see if it-
higher, but
That's really good.
yeah.
Hardly any compression
Yeah.
on this side
Yeah,
at the
I can
moment.
feel it.
Once I put that, turn around so these guys can see how big this extra strip is. It's not much,
It's working.
but it's just on the right area. Yeah, and that's because my assessment told me to put it there. Does that make sense? So when we redid the test, this fired up and you felt it pop into my hands, and I knew that we still needed to settle that neural system down over that area. And because I think it's quite a good significant change, the tone dropped right down, I'm actually going to reevaluate her other positive tests, because I think we actually might have improved it. This was always, no, this one was good anyway. I'll get your line face up for the other tests because they were still slightly more positive. So lateral flexion here, hold there, don't let me push across. See how it's a big difference. That extra pink strip was a lot of change for you.
Yeah.
Yeah. Here, hold there, don't let me push across. This is good. Lift your head up. Should feel good. Yep. Coming back, let me sit you up. Right now, I would say I don't need to take this up.
I kind of like my shoulder feels light.
Your shoulder feels light. Yeah. Again, a good assessment takes a bit of time, but it means you're not wasting your time and you get such a maximal effect for a little bit of intervention. Now, guess what her homework is? Yeah. So, you know, rather than doing rotator cuff exercises, deep neck flexors, whatever, I just needed to stretch it. And the thing is, now that it moves and it functions better, it won't hurt to stretch, because leading up to this, she couldn't even get a stretch
Yeah.
to it. Yes, that's right. So she's not doing the stretch because it makes her symptoms worse. Can you see why patients cannot, it's not because you don't want to be compliant to a home program, but I'd be telling you to stretch that muscle, you would be saying it makes my headache worse, so why would I choose to do that to myself? And you've got to be a very good therapist to convince the patient to keep pushing through that headache till you get yourself better. Now that we've got the movement without the discomfort, she's going to be compliant. And the goal is for her to keep that tone down. If she doesn't do any stretches, can you see how it's still going to work just having the tape on? Things will just normalise while the tape's on. Her shoulder feels lighter. The economy of movement is there. There's less work through the system. So just being in a better position will give her relief. But whenever you can, just stretch her real.
Yeah.
Yeah.
Can I ask, you know, say with say environmental occupational things, like these are reinforced through different positions we do today. How often do you find someone may need a top on an application? Say they stop and they've kind of got out of the practice and getting
Yep.
on habit.
So it depends on whether you got to the crunch. So if I think this is the top of the hierarchy, then I focus on this, and then I find out environmentally what in a day keeps on provoking this. Now, if I'm lucky, I've got a good therapist who looks after themselves. They've put everything in place. So they've told me they do deep neck flexor exercises, they do the Pilates, they do whatever. And despite everything they do, they still have their symptoms. That's the patient where I'm really looking forward to treating them, because all I need to do is get the tape on the right spot. And because they've done all the legwork leading up to it, once I get it in the right spot, all those other muscles have been working anyway. They've just been working in a non-optimal position. As soon as she gets onto those exercises, it's actually going to maintain what we've done. That's very different to, say, I've taped her up, it frees her up, but then she goes back to work and she doesn't actually do anything in her spare time to readdress these compensatory patterns. Obviously, this muscle is tight, it's causing compression, and it could be the problem, or it could be compensating for something else. So if you get the top of the hierarchy, you get a better success rate for shorter amounts of treatment. It depends on whether you got the top of the hierarchy or not. And I say that because I've had like I said, I have lots of people who volunteer themselves for hip labs, and I had one lady who had 30 years of hip problems. And she could say it to the day because it happened with her child, who was now 30 years old. Her hip Favors was positive, she couldn't get it down. She did her yoga, she's done Pilates, she gets regular work on it with massage therapists, so of course, she's doing everything right. So literally for her, we taped her up for the hip, so very similar to the taping that you guys saw, taped her up for the hip, leg came down, power came back. And I said to her, now that your hip is functional, every time you sit down, I want you to sit and stretch it out so that you maintain what the tape has been delivered to you for, which is hip range of motion. So in other words, I've taped the scalenes, I need you to maintain the scalenes length so that when the tape comes off, your body is aware of where it needs to be, what it needs to do, and so that we may not have to put the tape back on. Now, 3 months later, she came back into a course and signed up for a course. She said the one piece of tape that I put on her, she left on for 4 days. Throughout that time, she did her hip stretch, and her hip problem for 30 years never came back. And like I said, sometimes it is just finding the key to open that doorway for the person, particularly if they've been doing everything else they can to help themselves. And like I said, the patient has to work on helping themselves too. All right, so for the exercise though, I do want to just show you the muscles around the back and sternocleidomastoid, just as like, not that you need it, but I'm going to show it to you guys, but not on this body. This body's happy at the moment, isn't it? It's very happy. Yeah. See, even though you're going out, you're going to leave this on. It's a good look. All right, so what I'm going to do now is we're going to do the battery test again, because who remembered all that? No, exactly. Okay, so we're going to partner up and we're going to go lie down, and obviously if you have a neck discomfort or a shoulder discomfort, you want to nominate yourself first. I'll go through the testing, and then depending on what we find, we'll then show you how to do a sternocleidomastoid taping or a splenospicus capitis taping so that you know how to apply that. All right, so let's find a bed. Does someone else have a neck problem and sort of saying, oh, I wish that was me?